Hi, everyone, and welcome to today's webinar, InferOperate Thorax, a surgeon's perspectives. My name is Swati, and I'm delighted to be your host for this session that will be very insightful. Today, we will be exploring how our kind of latest technology, our InferOperate Thorax tool, has been making changes in the thoracic surgery space. So as a quick kind of recap, it provides a rapid 3D reconstruction of the thorax, allowing surgeons to enhance their pre-surgical planning and recognize any anatomical variations that may be there and help them make more informed decisions about their surgery. So today we're honoured to have two distinguished speakers with us. We have firstly Mr. Joshua Lodia, a consultant thoracic surgeon at Leeds Teaching Hospitals NHS Trust. He's been there for now 3 years, and prior to that, he was training at the Yorkshire and Humber Deanery. He's been using 3D reconstruction software for about 3 years now and has experience in creating these 3D reconstructions in his practice. We also have Dr. Boris Grief with us. He is an assistant professor and head of the clinical department of thoracic surgery at the University Medical Centre of Ljubljana. And he is also very esteemed, has very experience in thoracic surgery for over 10 years, and has a specialist interest in minimally invasive anatomical lung resection and lung transplantation. So we're very happy to have you both here today, and thank you for kind of coming on to share your experiences. So this is a 30-minute webinar. So for the next 30 minutes, they'll be sharing their kind of first-hand experiences with InferOperate Thorax, including their real-life cases. So it will be very exciting. So without further ado, I won't be talking any longer. I'd like to invite Mr. Joshua Ludia to talk about some of the experiences that he's had and to go through a case that he has prepared for us.
Thanks again for having me today. So, let me share my screen and just let me know that you can see that.
Yep, we can see.
Fantastic, great. So I'm kind of going to jump straight into it, given the time. I have a scan. I'm not going to go through the details necessarily of the patient. I'm going to slow this down. Which segment would you resect? It's a supposed lung cancer. Let's say it's confirmed histologically. I'll give you a hint that we're looking at the right upper lobe here. And there we're looking at a T1B N0 M0 staged, let's say, adenocarcinoma. And usually for this, for this size and the fact that it's nice and peripheral, you'll be probably looking at segmental resection ideally. Given the fact that I know, say, we've confirmed that there's no nodal involvement here with good staging preoperatively. So prior to using 3D reconstructions, I would chat to the patient in clinic and kind of tell them that it would be maybe a segment, maybe two, maybe a lobectomy. I'm not yet sure. I'll have a look in theatres and you'll find out once you kind of wake up, which isn't really that ideal. And prior to this, I'd use lots of other softwares, and I would kind of upload the scans a couple of days to sometimes maybe a week, or if I was doing it myself, 4 painstaking hours later, I'd have a recon. But that would all happen either prior to or after I've chatted with the patient, and prior to surgery, effectively. So I would know that information. The patient might not necessarily know that as much information. But what I can now do, which is one of the key things I love about InferVision, is that I actually do this. I start my clinic, and I download the scan before I call the patient in. And then as I start the conversation, I swing and upload it up to InferVision. And by the end of the conversation, I've got a 3D recon, and we can both go through it together and actually plan and say, right, this is most likely the kind of procedure you're going to get. Yes, there may be some variation, but it's less likely to be so much of a kind of catch. I was saying that you can see the multiplanar view, so let me just show you that. There you go. So you can actually, you would have thought that this would be either in the either posterior or maybe apical. You would have thought that the anterior is less likely to be involved, given the fact that you see that bronchus come off there. But actually, when you look at it on your 3D recon, once you've got that up, let me zoom in. There you go. I'll take that off for a second. you can actually see that the lesion in yellow here sits, it certainly is in that posterior segment, but in terms of a margin, you're going to question whether you've got a good margin there, especially once you put that. That's obviously a 2 centimeter margin, but you can tell that all segments are actually involved. So I actually did do a lobectomy in this patient, but in terms of the resection, that bit's somewhat irrelevant as to what you actually ended up doing, because there's debate on that to no end. But the point is that I could have that conversation with the patient and actually put that forward to them and say, look, I could do a segment 1 and 2, but in terms of recurrence risk and this and that, I could have that discussion because I knew prior to actually operating and discussing it with them. So that's kind of the one key thing that I definitely find useful with the InferVision. I'm going to slow this one down too. So straightforward lobectomy. I presume you don't need to see that, do you? So straightforward lobectomy. This is a patient who's had clearly some other surgery before, breast cancer. But in terms of our perspective, there is a right middle lobe lesion, which will be evident shortly. There we go. And you might think, okay, it's a lobectomy. Why am I going to consider doing recon for a lobectomy? And actually, this is probably one of the biggest things I've realized the more and more I use recon, that I pretty much use it for as much as I can in the way of resections. That goes beyond lung resections too. But it's mainly lung resections at the moment. But looking at this scan in the actual views, you would kind of just take it on face value. You're doing a right middle lobectomy. It's going to be relatively straightforward. And there's not going to be that much issue. But then you actually go, and I'm going to stop sharing and reshare. So the key thing that I find it useful in terms of not just segmental resections is knowing the anatomy before you go in. It's so much more useful knowing exactly how many vessels. And yes, you can figure that out on the kind of standard 3D, the standard CT scans. But when it comes to anatomical variations, it's highlighted so much more readily with the 3D recon. The way I kind of use the analogy is that yes, you can put central lines in without using ultrasound, but isn't it a lot safer to do it if you have that additional knowledge all the time?
I could just ask you a question. So obviously you've had a lot
Yeah,
of
go for it.
experience now using the 3D reconstruction. Kind
Hmm.
of what were your initial thoughts prior to kind of using it for the first time? Did you have any kind of worries, or were you worried about any of the challenges it posed, anything like that at all?
I think prior to using 3D, not just this platform, but other platforms, it's the how confident can I be that what I see is actually going to be what I get. And I guess I'm an early adopter, so I never really had the issue of, well, I've always looked at the CT scan. What additional information is this going to give me? I think I got over
Yeah.
that hurdle pretty quickly because
Okay.
I like tech. Um, but even if that is the case, and you are thinking that, I would probably say use it a few times and just be a bit open-minded, and you'll be surprised how quickly in just a few cases, you'll realize it gives you something that you hadn't necessarily realized with just the CT scan. And initially, it might be a minor point, but at some point, like in this case, that hopefully it's loaded up while I'm just, there we go. Okay, it's loaded up. I'll share my screen. So you'll see in this one as well, and that it can get you out of a tricky spot in times. There has been a case in which well, I'll show you this one. So this is that middle lobe lesion,
Hmm.
which is there that we saw on the scan. Now, you've got your superior vein there, you've got your inferior vein. Your inferior vein is, well, it's kind of almost a trifurcation, isn't it? You've got that superior vein, your middle, and then your lower there. Um, and normally, if I was seeing this operatively, I would quite easily identify that as the upper. I would see the fissure there, and I'll probably take that lot of vein. Because in this one, the fissure was incomplete across here. So you'll be seeing the vessels here, and you'll probably take that vein. But actually, it's clear on this with the recon that if you did do that, you'll be sacrificing some of the venous drainage of the lower lobe. I'm hoping that that's evident. Try and hide some of the arterial stuff. But yeah, so I should actually mention that in this, it's obviously red, that's venous, and blue, that's arterial. So if I was to take that, I would sacrifice some of the venous drainage to the lower lobe. So it's aberrant stats like that are kind of the useful things when it comes to the 3D recon, even in the lobectomy setting. So yes, I started off with using them mainly for segments to highlight which segment I'm taking out, but then also to make it a lot easier in terms of figuring out how many branches I'm going to find, where I'm going to find them, especially if you're looking at kind of subsegmental resections. But then the more and more I used it, the more I started using them on even the kind of lobectomies. And we know that anatomical variations in the lung is pretty much like 20%, if not a bit more, depending on which paper you decide to read. So it's not uncommon. So yeah, that's the thing. And then specifically, as I mentioned with this platform, the one thing I definitely love is the fact that I can upload a scan within 4 to 5 minutes. I've got a recon, which, like in this last case that I showed you with that aberrant anatomy, I got in and that's exactly what I saw. I dissected a bit further on that vein, and that's exactly what I found, that actually, if I had not dissected that fissure and taken the vein just as I saw it, I would have been taking some of that vein to that lower lobe. So yeah. So I did write a little point on here about don't forget the bone and skin layers. You have got the ability to look at bone and body, and I have used this in rib fracture cases as well. It's quite handy. You know, being able to identify the ribs and also using this, the kind of actual surface anatomy to then say, right, okay, so if I undo that, then your incision's going to be relative to wherever those fracture lines are going to be. So yeah, don't forget it can be useful not just in the parenchymal space, but also in the kind of everything else in the chest space.
Great. Sounds like, you've had lots of experience using different use cases as well. So not just kind of the traditional kind of segmentectomy versus lobectomy, but you've also found it useful when you would traditionally do your lobectomy and kind of stick to that plan as well. So at this point, I do want to ask if there's any questions from the audience, and please put them in the chat box. We'll get them answered, perhaps towards the end as well. So thank you very much. We'll now move on to Dr. Boris Grief and his experiences using InferOperate Thorax.
Good evening, everybody. First, I would like to thank the organizer for inviting me to be a speaker tonight. It's a real pleasure for me. I start sharing now my presentation. And we've been using now this InferOperate Thorax 3D platform for about 1 year, and we performed nearly 50 cases, 50 segmentectomies. To start with the presentation now, I hope you see it.
Yes, we can see.
This is a case of 66-year-old female patient, smoker, previous history, surgery for the NET tumor of the appendix, and further on follow-up. And there was a PET dotted lesion in the right upper lobe, as you can see here on the CT scan. In all the sections, you can see, and then follow the CT thorax, which showed cystic lesion suspected for low malignancy adenocarcinoma. PET scan was low metabolic activity, so the pathological clinical stage was CT1B with no involvement of lymph nodes, and the lung function was good. And now the question for all of us, for the audience, which segment to resect? Prior to use of this 3D platform, we would go most probably for for bisegmentectomy because even radiological report concluded that it's like in the apical segment. And it can be really in the border between all the three segments. So even direct lobectomy could be accounted. So which segment? Now you can see here already showing the 3D reconstruction. 3D reconstruction, you see the tumor lesion here, cystic lesion, actually positioned in the anterior segment of the upper lobe, but just a small amount of the lesion extending into the posterior segment, but also close to this border between all the three segments. Taking into the consideration that the lesion was not histologically verified, we decided for a segmentectomy of the anterior segment, but here you can see the tumor margins as the tumor was really superficial, I mean peripheral. We didn't expect to have any real trouble completing the anterior segmentectomy, including also a little bit of parenchymal division, including the posterior segment. Now I proceed with this video. I hope you still see my presentation. I hope you see the video playing, how we actually plan this procedure. First, what's very useful in this platform that you can use the bronchial segmental anatomy to see any variation, and then of course you can correlate with bronchoscopy. Then parenchyma, you see now the tumor in the anterior segment, but very close to the posterior segment, actually invading a little bit of it, and now the tumor and the corresponding margin. So then we move to the lobes mouth to get rid of unnecessary structures that might confuse you during the planning. And then with the vascular anatomy, we investigated all the veins and arteries. You see now the venous pulmonary venous anatomy with three of the veins here anteriorly. There was also additional vein more posteriorly in the intersegmental plane. And you see the lesion. And then we moved on to the pulmonary artery anatomy, which showed 4 of the segmental branches. So we find it really useful in this platform, how you can plan prior to the surgery. Maybe I move back a little bit. Didn't stop, but part of it is missing. This is venous anatomy, but I don't know how come that there is no arterial. But I will show you now later during some photo from the surgery. Now you can see the pulmonary vein divisions, all the 3 branches here in front, 1, 2, 3. And as already mentioned, there was additional branch more posteriorly. We divided together with the parenchyma. And now the pulmonary artery division. Here you can see now the 3D reconstruction with four of the arteries. I hope you see it well here. Behind is a bronchus. This is first, second, third, and fourth. Actually, 3 on them around the segmental bronchus. And now, if we go here to the photo, I hope it is not too confounding. One thing I want to emphasize, in case of a little bit of challenging dissection, this case I cannot say it was really straightforward. A little bit due to the lymph nodes, we were just a little bit as a bothering us with the dissection. But anyway, if there is a tight contained space around the bronchus with many arteries, as you can see here, still not divided. One branch, second one, and third. I see the one already divided. Around the bronchus, there is not a lot of space to divide the bronchus with the stapler. In such a case, there is one trick we can use that we cut the bronchus sharply, like with the scissors, and then in the end we staple the stump of the open bronchus when the segment is removed. I think it facilitated the dissection. You see this here, the retraction stitch, making more space with the dissection on the arteries. So now in the lower photo, you can see all the four stumps of the pulmonary artery. This is the bronchus that was cut and stapled at the end. And now here you can see how we dissected the bronchus and then cut with the scissors. And at the end, when the segment was removed, we just retracted this retraction stitch and stapled the open bronchus. And we find this way very useful in case of not a lot of space deep in the parenchyma. Another thing I already mentioned is very necessary, very important to do the good lymphadenectomy, of course, in terms of oncological perspective of the procedure, but secondly, very importantly, to just remove all of the lymph nodes, to throw the anatomy to see it, and then to complete the section and division of all the necessary structures. I've forgotten to mention that we use this 3D platform here, in this case, in the combination with the ICG intraoperatively, which really facilitates the interparenchyma, intersegmental parenchyma plane to divide with the stapling divide at the end of the segmentectomy. I think it's very useful. You can plan, if we go back to this slide, showing how we need to extend our parenchyma margin into the posterior segment of the upper lobe. And with the use of ICG, it's really nicely because you nicely and reliably define the intersegmental plane, and you can just extend your parenchyma margin into the posterior segment. And now I go back to this ICG slide. We also check at the end, especially if there is any doubt that maybe remaining vessels, like remaining pulmonary veins, like you can see here on the photo. So the apical segment branch or posterior segment branch sometimes can be compromised with the stapling line. If in doubt, you can use it at the end to see how it is perfused with blood. You see nicely both branches are nicely perfused, and there is a good outflow from the lung, and you're not like worried that anything was like compromised. But if there is a compromise, you can even extend the procedure directly to the lobectomy if there is no outflow. And to conclude my presentation, there was unfortunately redo because of due to the bleeding. There was half a liter of hemothorax on the first postoperative day, and the bleeding was from the utility incision, but no blood transfusion was needed. And afterwards, it was uneventful. The postoperative period, and the patient was discharged on the fourth postoperative day. And what was a little bit of surprise, but not so much, as I said, the lesion was not verified, suspicious for low malignancy adenocarcinoma, but histology just ended to be benign. And that's why it's good to stress out once again. If I go back to this slide, if we have a tumor in such a localization between the segments, and there is always possibility to think even about a bisegmentectomy or even lobectomy. But when you don't have a histologically verified lesion, I think it is must to have a good plan before the surgery, like we had using this platform to decide for the segmentectomy, because the case at the end resulted to be not malignant. So thank you very much for your attention.
That's great. Really interesting, particularly kind of how it was intersegmental. Really interesting approach there. Thank you for sharing. I guess question before I open it up to the floor to both of you, just in terms of obviously accuracy and reliability is essential when you're making these kind of crucial decisions. What has been your experience using the 3D reconstruction tool?
Before we started, actually, the expectations were really high because we had quite a lot of feedback from other colleagues from other centers. But anyway, without any experience, we couldn't know where we are going to. But anyway, it really quickly resulted to be a real game changer in our dynamics of work, and it proved to be really a reliable system. And as already heard in the first presentation from the colleague from Leeds, that it is really that you know the anatomy, all the variation before you go into the surgery. You still need to do the surgery, all the dissection, but all the worries are taken away, most of them, and you know the variations, anatomy, how many vessels. You can plan the intersegmental plan very accurately and reliably, and I think it's a really useful thing. I don't imagine to do it without 3D anymore.
Well, really happy to kind of hear that you've had such positive experiences. So we have had a few questions just in the Q&A, so I'll just kind of open it up to both of you. So first question is, can it give like the segmental anatomy? So kind of I think what they're asking is kind of how detailed is the anatomical reconstruction that you do end up with?
Yeah, the segmental anatomy is really good, even down to a subsegmental level. And that's again something that I'm surprised that you get that within 4 or 5 minutes with a fully AI tool, but it's accurate, and all of the other ones that I've used, including I've done manual reconstructions and semi-automated reconstructions myself. You end up going down to at best segmental level. So the fact that you can actually do subsegmental resection should you wish and know your anatomy really well before you even get there, it's great. Yeah.
Okay. And the next question that I have is, can it show the lesion, or do you need to draw like a region of interest? How does that all work?
So that again, that's a really good point with this. With this platform. Oops, sorry, I just lowered the chair. With this platform, it's correct me if I'm saying anything wrong, but it's been actually designed on a lung cancer screening database, hasn't it? So effectively, it's been initially designed to pick up nodules. So I'm not sure if you saw when I was showing the screen live, but it picks up all the nodules, whether there is something actually there or whether it's just a bit of atelectasis. But it kind of highlights a lot of nodules, and in fact, that's something else that I found really useful, because there has been a time in which I was doing a robotic lower lobe recently. I had to convert because of bleeding, and if it wasn't for the fact that I converted and also the recon, which highlighted these other lesions, I thought actually I did know that there was something in the right upper lobe. Let me just go and have a feel now that I've actually got my hands in the chest. And lo and behold, there was something there. It turned out to be an adenocarcinoma as well. All nodes were negative, so there were 2 synchronous primaries, but it saved the patient from having another operation and more unknown, uncertainty down the line with scans and things like that. So yeah, it's definitely good at picking up other nodules.
Okay,
If I can go back to the first question about the segmental anatomy, what I learned, and I should say honestly, that really surprised me a little bit, because from the books, as we say, there are some anatomical variations, and of course, some anatomy is more frequent than other in terms of how many segmental vessels you have, like veins and arteries. But anyway, I think I can say, maybe it's gonna sound like a little bit of controversial, that every specific patient is a little bit of variation itself, because you see a completely different perspective in the 3D mode, in the correlation with the tumor, relation with other segments. And what is another thing, what I learned in this 1 year experience using the InferOperate platform, that how this intersegmental plane is like anatomically expressed in each patient, because you have having a look at the CT scan like we had in the first case, even radiologists reported to be in an apical segment, but actually you see the precise intersegmental plane, and you can really plan very effective oncologically of course, segmentectomy, and even in case of some metastasis or some wedges anyway, you can do it like some metastases that are really in between the segments, and helping your technique using ICG as well, I think is good combination, and it's really good anatomy, and also in terms of parenchyma, not only the vessel structures and tumor itself.
So actually, so I was going to add to that, if that's okay. So you make a really good point, because that there is one difference with InferVision and other platforms in terms of the way that they create the parenchymal segments. InferVision use vascular, a lot of the other platforms do, but a lot of the other platforms also use the bronchial anatomy. And I know that there are debates in terms of actually it should lead to the same parenchymal division, but actually no, it doesn't, because I've manually segmented them separately with using the vascular and the airway, and you do end up with slight variations in terms of those boundaries. So especially when you tie it in with ICG, because of the fact that your 3D recon has been using the vascular structures for your segmental divisions, it ties in really well with the ICG.
Yeah, I agree.
Okay. We have a few more questions on the chat. I know we're going a little bit over time, but hopefully we can answer these. So your first question is kind of, do the CT scans need to be sent outside the trust? Have you had any issues with information governance, particularly in like the NHS? That's the first question.
I guess I'll take the NHS question. So yeah, in terms of the NHS, there are a few different service methods in which you can deal with this. You can either have the platform where it's fully online, you download the scans and you re-upload them onto their system. The alternative is that you have a server that's put onto your trust server, and actually it stays all in-house. So there are ways that it can make it a bit more IG safe, which trust should be happier with.
Brilliant. And the next question, which can be for both of you, is what kind of scans are you using? Are you using contrast, or can you use non-contrast CT scans as well? What have been your experiences with both?
Yeah, before we started to use this 3D platform, it was really an issue, because sometimes we were like, they referred the patient to our clinic from all around Slovenia without a contrast CT scan, and this was really a suffer to proceed to the segmentectomy, and our radiology department was really fully booked with a lot of CT scan. There was always a struggle and discussion what kind of CT scan we deserve to complete to proceed to the segmentectomy, and we always insisted that without the CT scan with the contrast, you cannot plan your segmentectomy, and we really struggled when we started our program. But now, when we have this platform available, it's way easier. It's really a game changer, and we really can. It really impact our decision making. So it's a crucial thing.
Yeah. So in some, so to add to that, in some of the earlier ones, I had. Firstly, other platforms, most of them will accept non-contrast scans. Most do struggle more when you've got a non-contrast scan. I'm yet to see this platform actually get it that far wrong. It's actually really, really accurate. To the point in which I actually had a patient where I had a non-contrast and a contrast. I questioned it after I'd uploaded the non-contrast, uploaded the contrast, and it showed me exactly the same thing. So I was like, okay, fine. It's pretty safe. It's pretty on the money.
Okay, great. One more question has popped up. So again, a question about integration. So they're asking if it's similar I don't know if either of you have used Ethicon before. Yeah, so if you want to share your experiences.
Yeah, so I didn't want to mention names, but yeah, that's the one platform where you have to have a contrast scan, and for me that was a non-starter, for the similar kind of reasons that you mentioned, where you get patients from not necessarily your trust who don't necessarily do scans by your protocols. I've gone as far, so in terms of scan depth and things, 1 mil is fantastic, but if you don't even get that and you get kind of 2 mil scans, I've used those. yes, it might be a bit more jittery, but you know, less refined in terms of resolution. It still gives you a really good kind of view of what you're expecting. But yeah, in terms of that specific platform, if I'm not mistaken, unless they've changed it, I have highlighted there that that is an issue. But yeah.
Okay, that's great. Well, yeah, thank you very much for answering those questions for us. I think everyone's found them really valuable. So just to kind of wrap up, obviously we're coming to a close on the webinar. So I guess lasting questions for you both is for surgeons who are a little bit on the fence about embracing a new tool such as InferOperate, what would be kind of your piece of advice to them?
Do you want to go first?
Yeah, I can go. Thanks. I think we all need to be like open-minded to get to start with new standard. I think this 3D platform is one of the new standard game changers. Is gonna really not make a revolution, but this is an evolution process in the thoracic surgery. I think that this 3D platform is in one very important tool of this evolution process, and I think we all should like. Open mind, way to follow it and to improve it, to use it and share the experience and help each other.
Yeah. So as I said, I'm an early adopter with stuff like this. So you could argue that I was always going to start something new and do something and have very few kind of cognitive limitations. But that being said, I work with a whole host of colleagues, and we've all moved to that, 3D recons. And if we've all got to a position where some were skeptics before, to now a position where none of us will do a segmentectomy without a 3D recon, it kind of speaks volumes. Once you've used it, you will not want to go back. As I said, it's like putting an ultrasound in putting a central line in without an ultrasound. Why would you do it when you know you've got something safer?
Yeah, no, that's great. Lovely. Well, thank you both again for kind of sharing your evening with us. I'm very pleased that you're both having kind of positive experiences with the platform. And yeah, thank you very much for your time. And thank you for all the attendees for kind of engaging and asking questions. It's been a really interesting webinar.